Welcome, everyone. My name is Sarah Morrison, and I'm with Foothold Technology. Before we get started, I just have a few housekeeping items to go over with everyone. You'll all be on mute for the duration of the webinar, but we'd like to answer as many questions as possible. If you do have a question at any point throughout the presentation, please send the chat message to Foothold Technology. At the end of the webinar, we will address as many of these questions as possible. And now I'm going to pass it over to Foothold CEO, Marlo Greenberg.
Hi, everybody. This is Marlo Greenberg. I'm the CEO of Foothold Technology. We are here today to demystify one of the most important topics in the world of behavioral health and human services, and that is the topic of interoperability. As many of you probably know by now, our entire industry here is slowly but surely staggering, limping, running, entering the world of coordinated care. From ACOs to health homes to RIOs, DSRIPs, all the momentum and all the change in the world around us is in one direction: coordinating care in an effort to increase the quality of care while lowering the cost of care. This idea has been around, as a lot of you know, in academic circles for a very long time, and even before Foothold existed, there have been many attempts to quote-unquote manage care. But it wasn't until the Affordable Care Act that real incentives were put in place to establish this framework for coordinating care and the infrastructure to support it, namely real incentive dollars. Of course, there's only one way to coordinate care, and that is through the interoperation of multiple health record systems. Healthcare in this country is provided by lots of different kinds of organizations using lots of different systems to track their operations, and unless those systems can speak to each other, there's virtually no way to coordinate care. Interoperability is how we will coordinate care in the future, simply because there's no other way to manage this complexity and the profusion of data that all these different kinds of care create. So Foothold has placed its bet on this. This emerging consensus that coordinating care is going to be the only way that care is delivered. And we've become one of the only behavioral health EHRs to establish live, real-time interoperability with multiple EMRs and health information exchanges. In fact, I'm not 100% sure, but I think Foothold is the only behavioral health EHR that allows you to receive a data file from, say, a hospital system and literally run down the data set that's in that file versus the data that's in awards and decide which pieces of data you want to exist in your own EHR. The ability to do this is called parsing that data, because you're placing data from another system into your database, and it means that awards can actually serve as a platform for your community's healthcare data. Another part of our commitment here, which I think is a substantial one, to assisting our clients in coordinating care, is helping to explain exactly what interoperability is and how it works. There's a lot of technology involved in getting two complicated databases to speak to each other, but the actual work from the user's perspective isn't insurmountable. This webinar is one in a series of efforts to help describe how interoperability works in the real world. And to that end, we've brought together what I think is a terrific panel. We've got Dan Lowy. He's the Vice President at Argus Community Incorporated, and he's going to be discussing his organization's role in and reasons for engaging in interoperability projects. We've got Paul Grabscheid. He's the Vice President of Strategic Planning for InterSystems. They are almost universally acknowledged as the leader in data exchange, and they are also the developer of HealthShare, which is the interoperability platform that Awards uses. And we've got Nance Shatskin, who's the CIO of the Bronx RIO. Bronx RIO is one of New York's most forward-thinking health information exchanges. The three of them are going to hand off their speaking from one to the next for the next 30 minutes or so. We don't have any slides. This is just going to be audio, and then we're going to have time for questions. So if you have questions, please feel free to use the WebEx chat feature. Our producer, Sarah, will get them and will keep them and can ask them when we're done speaking, or can even unmute some of you to speak too, depending on sort of how busy all of it is. So without further ado, I want to introduce Dan Lowy from Argus. Dan?
Hi, good afternoon, Marlo and everyone. I've been asked to speak on the webinar from a provider perspective and to discuss how we have been working with Foothold Technology to bring interoperability to the programs of Argus Community and also the outside providers that we are working with. We originally chose Foothold Technology because of their expertise as a behavioral EHR, but everything is changing and changing for the good, and even Foothold is changing to meet the needs in other areas that I'll talk about in a little while. But Argus Community as a provider has been established since 1968. long before the world of electronic health records. But we're a multifaceted community-based organization, mostly serving the boroughs of Bronx and Manhattan in New York City. Our services are grounded in behavioral health services. We have 2 Office of Mental Health licensed Article 31 continuing day treatment programs that serve duly diagnosed patients with a mental illness and an addiction. We also have 2 OASIS licensed Article 32 medically supervised intensive outpatient substance abuse programs, 2 Ryan White care coordination programs for people living with HIV, a very large health home care management program for people with chronic illnesses that has now reached over 1,500 people in census and actively engaging and outreaching thousands of people every month. We have 3 OASIS licensed long-term residential drug treatment programs, a state education department licensed counselor training program, and 2 OASIS licensed prevention programs. For those of you who don't live in New York, OASIS is the Office of Alcoholism and Substance Abuse Services. So Argus originally began using Foothold technology years ago in our residential drug treatment programs that were partially funded by HUD. And we were very interested in Foothold's ability to collect data and report HMIS data back to HUD. But around 2010, we began realizing that we were going to need electronic health records in our substance abuse and mental health components of care, and that we began using awards in our OASIS outpatient treatment program based on the fact that it has such a strong OASIS-related behavioral health component. And we began to integrate awards into another outpatient program that we acquired in 2012, and now we are fully on awards in both programs. In 2014, with the conversion of our COBRA HIV program to health home care management, we were told by the state of New York that we had to have electronic health records for our patients in care, that we were going to need to be able to share care plans from within Argus community to outside health home leads. And we started to wonder just exactly how we were going to do that. Well, we approached Foothold about the subject, and they were very open and flexible to helping us create care plans, create a health home care management model, and to meet our needs to be able to take our care plans and convert them into files that could be sent from Foothold technology to other people. We liked that feature so much that in the same year we added our Ryan White care coordination program, and Foothold was able to develop specialized tracks for our clients in that program, because they have to be tracked based on whichever track they get assigned to based upon their health-related condition. When we began the Health Home project in 2012, we also realized that we were going to be able to, or we needed to be able to flow information from our electronic health record to our Regional Health Information Organization, or what we call a RIO. We needed to be able to exchange information, and we needed to be able to have access to the RIO to be able to view patient information as long as we had their consent. So we approached Foothold about this, and Foothold was able to help us to develop a project with the Bronx RIO, where we agreed that we were going to identify patients that we needed to share information to a RIO with, and we began, Foothold began hosting conference calls and webinars to help us develop this pilot project, which was something that lots of other care management agencies in the state of New York were simply not doing yet. And I'm really proud of the fact that we are one of the first care management agencies in New York State to be able to share information from Foothold to the RIO. Foothold helped us to establish spec files, to match patient information, to help us transmit data. Oftentimes, Foothold would meet with the Bronx RIO without our involvement to work through the project on a technical level, far beyond our clinical level. Where we as a provider came in involved a lot of patient matching and crosswalking, resolving errors like duplicate records found, deciding which clients and what information would flow from Foothold to the RIO. And Foothold was instrumental in pushing us forward from getting clients to sign manual consents to actually signing electronic consents and using electronic signature, something we were not doing in the past. So this project on many levels felt like a heavy lift to us. At some points, however, Foothold and the RIO really are the ones who did most of the heavy lifting and did everything in their power to make it as easy as possible for us, to make interoperability as easy as possible for us. I just wanted to close with saying we continue to work with Foothold and the RIO on this project and work with Foothold on other projects. We've been very happy with Foothold's ability to respond to our needs and develop functionality to accommodate us. And if I could say any last words, it would be to put upon folks that interoperability is something that's going to happen. We have to accept it, and we're all heading there. And Foothold did everything that, and continues to do everything to make interoperability a reality for us. That's really not that hard at all. So I'd like to now pass it on to Paul and thank everybody for listening.
Thank you, Dan. My name is Paul Grabscheid from InterSystems, and as Marlo said earlier, we are a technology supplier that I hope is almost entirely invisible to all of you. And that may sound like a strange thing for a vendor to say, but I always describe our role as being akin to the plumbing in your house. You definitely want plumbing, and almost every day it works, and on those days you probably don't think about it at all, and any day you're thinking about the plumbing is a bad sign. So our job is to make the plumbing as efficient and invisible as possible. So what does that really mean? Well, what our technology needs to do is actually just a few things. We need to be able to connect to virtually any kind of healthcare system there is out there. So maybe that's a little bigger than simple, because there are unfortunately a huge number of different healthcare systems, but we need to be able to connect, you know, to the vast multitude of systems that are out there and get data from those systems. The second thing we need to be able to do is to combine that data together in useful ways. What a person wants is to be able to get as complete a picture as possible of the patient that's sitting in front of them or the patient in whose care they're involved. And it may be the data they need comes from lots of different hospitals or clinics or doctors' offices or laboratories or other healthcare providers. Our mission is to combine that data together and be able to present a kind of holistic, aggregated record from it, because that's what the person wants to see. They don't want to have to do all the work to try and piece these things together. They want to see this whole. One of the challenges that we have in doing that is that healthcare includes an enormous amount of terminology, names of, you know, conditions or diagnoses or tests or lots of other things. And unfortunately, terminology that historically has not been used very consistently. So one of the things that's often a real challenge in putting large information networks together is getting the source data into a common format, into a common set of terminology. So that's something we do in our software, at least as much as we can, to try and normalize the data, to try and get it into a consistent and consumable format. The next and very important thing we need to do is protect patient privacy. And that's important because the patient deserves to have their privacy protected. It's also important because the organizations using our technology have a legal obligation to respect the patient's wishes and to protect the privacy of the data where that's required. So what our software does is to enable organizations to set up consent policies, and then to capture patient consent, and most importantly, to enforce patient consent. So to be able to only release data or only release that data for which the consent is present. We also have the capability in the software to be able to keep track of who has seen what data, at least who has accessed what data, and to provide an auditable record of that. Again, that's generally a legal requirement. So users of this kind of technology need to know that that's in the system, so that those legal requirements can be met, and you can answer the question from a patient who has accessed my records through this means, and what did they access and when. And finally, we need to be able to do all of these things at scale. Sometimes we're involved in systems that have a local scope or a regional scope or a statewide scope or even a national scope, not for a country yet as big as the US, but for some European countries, we do nationwide systems. So that in general is what we do. We were very excited about the opportunity to work with Foothold because we have a very expansive view of the world of healthcare. We have spent a lot of our corporate history working with hospitals. Hospitals tend to think they are all of healthcare or almost all of healthcare. And a lot of the work that's gone on over the last 10 years has been about connecting hospitals to each other, connecting hospitals maybe to clinics and doctors' offices, but with a pretty narrow view of the patient and the healthcare world. And we are very much focused on bringing all of the different corners of healthcare into a unified kind of network so they can talk to each other. And I can tell you, outside the US, there is a tremendous focus on bringing the world of social services and the world of healthcare closer and closer together. We're working right now on a national project in England to connect child protection agencies to healthcare, and to try and do that at the national level, which is really hard because there are lots of local and regional child protection agencies and lots of local healthcare organizations. And they're not very good at working together, but they have set as a goal in England to try and get 100% connection. So if a child shows up in an emergency department in any hospital, there is information available to whoever is doing triage there if there is relevant information about past child protection issues for that child. So that's something I think we're going to see more and more, in bringing the world of behavioral health and social services and traditional health care closer together I think is a very important mission. I think it will, in the end, make healthcare both more effective and more efficient. And it will particularly help serve the needs of a segment of the population that has not been so well served in the past. So, that is our technology role, and often we have a frontline organization like Argus on one side, and the operator of a regional health information organization or a health information exchange, such as Bronx Rio, on the other side. So it's probably appropriate that I'm sandwiched in between Dan and Nance, because we are kind of the wire that connects those two worlds together. So I'm going to turn things over to Nance, and she can give you the perspective of the operator of health information exchange system.
Thanks very much, Paul. I was asked at the beginning to give just a little bit of an introduction about myself, so it's in my notes that I'm going to do it before I jump into talking about the Bronx Rio specifically. But I started my career in healthcare in the very early 1980s, working for the New York City Health and Hospitals Corporation, which I think even people all around the country are fairly familiar with. As a major provider of health care to the insured and the uninsured consumer population in New York City, and then spent time at an academic medical center at State University of New York before moving on to St. Luke's Roosevelt and Beth Israel hospitals, actually as they merged to form an important New York City healthcare system that has recently been subsumed. It was called Continuum and has recently been subsumed by Mount Sinai. I say some of that just as a way of illustrating that I have seen a lot of health care in New York, including a lot that has very broad spectrum of services that it offers. 10 years ago, I was asked to write the technology section of a grant to New York State. New York State had a program called HEAL 1. They're now up to about HEAL 22 or HEAL 23. But this was a grant program that was going to give money around the state to begin to foster health information exchange. And the major healthcare providers in the borough of the Bronx in New York City came together and said, we want to apply for this. And I helped them by writing that technology section. They were awarded a fairly significant grant along with a dozen others around New York State at that time. And so I've been engaged over these last 10 years as actually implementing the design that started out being words on paper has been pursued. I personally have been very active in what New York State has then fostered as a collaborative process. There were no rules of the road 10 years ago when we started. There are now some rules of the road, and New York State really wanted to try to get everybody to work together, and that's been called the New York State Collaborative Process. One of the key committees has been a policy committee on which I have served from its inception, and I have a particular special interest in not just geeky tech stuff, but in implementation and operations around computer-based systems, and then specifically out of these last 10 years in the consent and privacy issues, which I've gotten to spend quite a bit of time on. So the Bronx Rio was formed 10 years ago. It was a cooperative effort of the major healthcare organizations in the Bronx. The Bronx Veterans Administration Hospital has been engaged from the beginning, along with several major hospital systems and federally qualified health centers and long-term care organizations. And in the beginning, not a lot of social service agencies, but the Bronx Rio about 3 years ago, as talk about health home programs and shifts in an appreciation of the value of care management and case management were happening, the Bronx Rio really began to increase its outreach to organizations. So Argus, for instance, has been a member for several years and is one of many community-based organizations OMH licensed, Office of Mental Health licensed, and even substance abuse-related programs that are members of the Bronx Rio. Today, the Bronx Rio is just under 60 healthcare provider members, and I would expect that to continue to grow. There are several thousand providers with logins, although I won't suggest to you that they are all using the system every day or even using the system, as many of them have logins but may never have logged in. On the other hand, there are over a dozen facilities around the Bronx. Out of those 60 that are members, there are over a dozen who are accessing the system on every day, and those vary, of course, across days, but we see over a dozen different facilities logging in every single day. Things have advanced over the years so that what we started out calling RIOs, Regional Health Information Organizations, in New York State are now shifting to be called qualified entities. They are being certified. I'm very proud that the Bronx Rio just completed its certification process and scored 100%. So we have a certification now good for 3 years to be able to engage in health information exchange in New York State. And at a high level, that means managing the data and the data sharing, managing the users of that data. Key to that is consent, which Paul mentioned and which I'll come back to, and also a role convening and encouraging collaboration and discussion that advances all the kind of side issues that are necessary in order for this health information exchange to advance. So what kinds of services does it mean to have with health information exchange? One of the ones that we are the most proud of is subscriptions, which are also called alerts, which is the ability for the health information exchange to be able to push information out to providers that on patients of interest to that provider so that they get that data timely, quickly, and are able to then determine whether or not they want to act on it. So the Bronx Rio has a number of providers who subscribe to alerts that will let them know if one of their patients is admitted or discharged from an emergency department or an inpatient setting. So those subscriptions or alerts, I would say, are one of the most valuable services that RIOs have developed over the years, and I think we're seeing this happen in more and more states across the country, although I think we may actually be able to claim some ownership in New York for having created that concept. There's also a service called the data availability flag, the ability to alert in an emergency room when the RIO has data from other sources than the hospital of that emergency room. What's the reason for that? Emergency room doctors are really busy. You come in, you want to train them to always check the RIO, but they don't want to check the RIO when 3 out of 5 patients there may not be any data there. So the RIO developed a service where when it got the registration transaction in the emergency room, it would check and see, oh, do I have data from places other than the hospital of this emergency room, and then push back a message that could be displayed in the emergency room system, sometimes the same as their EMR, sometimes a different system, but let them know whether or not it would be valuable to go check the RIO. Another service is the service of a portal, that is a web view, to be able to go in, if you are an authorized user, and view all of the data that's available from the contributing data sources. And I'm going to talk about exactly what that data might be in just a minute. The portal view started as where all the RIOs began. That was what it was all about. Let's hurry up, let's build a portal. What we've seen over time is that taking people out of their daily workflow in order to go log in and look in a portal is much more difficult. It's the muscle memory discourages you from going to do that because you're in your own system or even not in any system. But to have to go log in and look in a portal is often too high a bar to get people to engage. And so we find the portal is important and it's the right tool in some situations, but being able to push those subscriptions or the data availability flag as a way to know whether or not to come into the portal and other methods of delivering data when it's needed, where it's needed, are very important for the RIOs to continue to develop. So another one that we've developed in the Bronx is an e-referral process, either for a home care referral from an originating source out to the home care agency. The home care agency reviews whether or not they can take the patient on, what their plan of care will be, and they push it back to the original originating and referring provider. Or a psychiatric referral, and then the ultimate report from that psychiatric evaluation getting back to the provider who asked for the referral in the first place. And so we've developed some of those kind of closed-loop processes where the RIO is almost acting as a post office assistance to diverse computer systems. You put the RIO in the middle in order to be able to smooth out those deliveries and not require point-to-point connections between everybody. Also, it's the RIO that can often play the role in knowing that your foothold MRN is one, medical record number is 123, but over at the hospital, their medical record number is 789. And so we're able to give people their local identifiers even if the transaction or message has come in with somebody else's local identifier, by keeping that master patient index with all those cross-references. There are still more services that RIOs are routinely providing. One of them is direct, which now is with a capital D, but the concept of direct messaging, secure email, for healthcare. The Bronx RIO makes a direct email account a byproduct of your membership, so with no extra cost. Providers, obviously, and many of you probably are familiar with going out to contract for direct services, and that, like the early days of email, those accounts are costing people money. So providers are signing up or shopping, and we've just built that in because direct wants to be more and more integrated as one of your methods of exchanging data. And then the last one I'll mention is analytics. The Bronx RIO was the recipient of a large CMS Innovations grant 3 years ago, with which we've built a massive analytics. It's really getting at the whole big data world of a massive analytics warehouse of the data that we've received from so many different providers in the Bronx, and we're doing more and more population health analytics and registry activities, but also finding that it creates another tool for being able to deliver data in the way which is most effective. So when it's not effective to look up patient A, then look up patient B, then look up patient C, but what you really want is a daily or a weekly report about those patients that you can work from, then we're able to do that from the analytics warehouse perspective, even if not from the concept of a portal web-based front end. So what kind of data is routinely available? Registration transactions, whether those are for outpatient or inpatient services, for specialty care programs, for program enrollment, like in a COBRA case management program, or in an ACO, or in a health home. And also more, as we're expanding to work with more health insurers, actual health plan enrollment is another kind of registration transaction that can inform what you can learn about a patient when you look in a RIO. Diagnosis and procedure information, very common. Allergy information, very common. Labs. The Bronx RIO has literally tens of millions of lab results available on the 1.5, I think it is, or 2 million patients who are today included in the Bronx RIO's Master Patient Index. Medication information, both inpatient, so that it's possible to see what medications a patient was treated with while they were in the inpatient setting, and also outpatient emergency room discharge medications. We still don't have nearly enough of these, as the systems that track medications are still getting to the place where they can push those out to share them with other people, but that's going to change quickly, and I think more and more will become available. Radiology reports, cardiology reports, again, the Bronx RIO really has tens of millions of these now available after a few years of collecting this kind of data. Those are visible as text reports so that you can just get at it and read them. The Bronx Rio is not today sharing images, but there are a number of health information exchanges that have included the actual radiology images as something that is available through a portal view, and we just haven't had quite enough push for it, but I think we'll see it happen in the Bronx in the next couple of years. Perhaps EKGs first, which is one of the ones I've been trying to do for a long time, as it would help in the ER a lot. Then there are a lot of other reports that include care plans, as Dan mentioned at the very beginning, but also discharge summaries from inpatient stays and just about anything else that's in a text format that would be of value for other members of the community to be able to access when that care was delivered somewhere else. Other data includes the providers and service locations, so it's possible to know that this registration was at the asthma clinic or the congestive heart failure clinic or some other kind of a clinic, as opposed to just being a visit at Integrated Delivery Network X, Y, and Z. And a little bit, as I mentioned before, this enrollment status in many kinds of programs, whether that's Health Home, ACO, or other programs. How that data gets into a RIO varies certainly by RIO, and Paul's comments about InterSystems, I can say quite honestly here that the Bronx RIO is not at this moment working on an InterSystems platform, but that I, as a technologist, am extremely impressed and very respectful of the quality of the InterSystems tools and highly recommend them. So I'm very glad to know that they're in the background working with Foothold. But key to the Bronx RIO, and I think Paul spoke to it as well, is flexibility. It's the ability to make it easy on the data source or the person who needs the data to be able to work with the RIO, not in this one prescribed way, but in any way that suits that organization. And so the Bronx RIO has taken a lot of pride in having that flexibility. Just to throw a few of those technical terms out there for when some of you go back to your IT people, HL7v2 messages, CCDs and CCDAs. These are standards that exist for XML formatted documents that are becoming much more popular. And then there's the old-fashioned flat files that we sometimes just got to go back to because that's what people can work with, and then that's what you've got to work with if you are the RIO. I think there's tremendous value here to the whole healthcare redesign that we're all finding ourselves engaged in, that RIOs help to provide. I think it's also important to recognize that a lot of those are still to be realized. Even though I've been doing this for 10 years now, specifically around RIOs, we have really only just begun to get even the low-hanging fruit, to really achieve the kinds of change and improvement that we look forward to. But pretty clearly, having data available when you need it, where you need it, regardless of the source of that data, is key to being able to make our overall system of healthcare more efficient and to break down barriers that will lead to improved care coordination, the opportunity for much better integration between physical and behavioral health, a reduction in repeat and unnecessary testing, the avoidance of potential safety risks to patients, alerts to providers that enable fast reaction and follow-up, and analytics to offer all kinds of new avenues for improvement, targeted intervention lists, metric tracking, registries. I think that goes on and on. And now I just want to touch on a couple of the tougher subjects before I close. What are some of the barriers to achieving everything we're trying to achieve? Because if all you folks out there understand, maybe it'll also help to break down some of these barriers. Muscle memory I mentioned before, so I think there's always the challenge that people are used to doing things the way they do them, and it's sometimes hard to get them to shift and do things in a new way, at least until you can get them to develop new muscle memory. But in addition to that, there are a lot of redisclosure of the information, redisclosure of personal health information data, concern about redisclosure rules and redisclosure concerns, regardless of the rules. There are also differing rules on consent requirements depending on the type of data. So HIV or mental health or substance abuse or genetic testing or minor consented services are all types of data that present special and or unique and or higher bar challenges that have to be managed in order both to meet the law and regulatory requirements, but also to build patient trust. And patient trust is really a large part of what drives all of health information exchange. In addition, the state of New York, and I think this has not been quite as true in other states, but it is happening in some, when they see data moving from paper to an electronic method, they see the need to add additional rules. And so in New York State, we have an additional consent for sharing data through the Health Information Exchange, whereas there would be, if it were not electronic, if it were paper, that consent would not be required. There are also, and this is also going on across the country, the development of new regulations, many of them still in draft, so you can't quite plan for them yet, but you know that they're coming. And they are largely to encourage solutions for the redesign of a lot of our healthcare system, the creation of health homes, of special needs programs for special populations to further integrate care and case management into healthcare to continue to expand the ecosystem as Paul was talking about before. And so those impending regulations create some challenges. Also, private health information exchanges. While in most states there's a real effort to build a public utility for health information exchange, a lot of the private or integrated delivery networks see a competitive advantage to controlling a lot of the data exchange, and in some cases almost set themselves up in competition to the public utility model. In closing, I'll just say where we are in New York State now is that we have 8 regional health information organizations. We hope that by the end of this year, they'll be communicating between and amongst each other. That will be a big step forward. Just this week, I had a very interesting conversation with our Office of Mental Health. I think that they have held back for some time in really pushing engagement in health information exchange because of their concerns about redisclosure and privacy, and I think that they're now looking for ways to be able to advance more aggressively, and it'll be great that organizations that are on foothold and hopefully other systems as well will be able to engage more as it becomes more and more expected that they will do that. So I'll leave it there and look forward to being able to answer any questions, and thank you for listening.
Terrific. Thank you, Nance. We've got a couple of questions here that I'll just sort of read off. If you have questions, please feel free to email them in the chat box on WebEx, and Sarah will get them and parse them and send them off to me, and I'll ask them. So the first one we have is, can you elaborate on what information is actually being exchanged with the RIO and in what format? So Dan, I don't know if you and Nance want to sort of tag team on this. What kind of data are you actually sending to the Bronx RIO right now?
We're sending mostly health home care management data from one of our health home care management programs. It includes admission and discharge data. Nance, correct me if I'm wrong, but it also includes some assessment and medical data.
Yes, and the care plan itself.
And the care plan itself, right. And we are also sending from our Ryan White Care Coordination Program. We're uploading care plans and medical information into the RIO as well.
Terrific. And Nance, what format is that going in? Do you know?
I'm guessing at that one a little bit, but I do believe that the care plan is coming to us as a PDF, actually, and being displayed in so that its format is being protected and it's a view-only document.
Okay, gotcha.
So it looks like a care plan if it were printed out of the Foothold technology system.
Yes, gotcha. Okay, good. Terrific. The second question, what is the status of developing interoperability between awards and the various health home data systems? I can sort of answer that one just because it's a great opportunity to sort of help folks understand some key distinctions here in this world. See, all this conversation we've been having with Paul from InterSystems, the health share platform upon which award sits that enables it to exchange HL7 and CCDs and even CCDAs with RIOs that are also sort of high-level professional interoperability platforms. That whole conversation is simply not happening at the health home level. The health homes have a motley assortment of systems that are not actually professional healthcare information exchange systems. So they're using sort of lightweight care coordination systems that cannot accept HL7 messages, cannot accept CCDs sent through various HL7 messages, or CCDAs that cannot send that data in any kind of federally standardized way. So the health homes in New York, this isn't the case all across the country, but in New York, the health homes have had no guidance about the kinds of systems that they would need to have, and so they've gone and chosen, frankly, any old thing, and that has made our ability to exchange data with them very difficult, especially when you compare it to our ability to exchange data with actual RIOs and the Shiny, all of which have sort of large-scale health information platforms that enable easy exchange and interoperability. So that is a good way to sort of understand the difference between, we're just kind of sending secure Excel files back and forth, or, you know, we've developed this homegrown system that mostly collects the data we want, but not in any format that anyone's ever seen before, from a company like InterSystems and the Bronx RIO, who operate from a set of shared national standards to exchange that data.
And Marlo, if I can just throw a couple of extra points in there.
Sure.
I think it's important for everybody to understand that there is a lack of standard on what is a care plan. So these HL7 formats and other things that we're talking about have not quite caught up with what are the critical documents that healthcare professionals want to be sharing. And the care plan itself is one that's kind of hopefully going to get a lot more attention over the next couple of years, so that there will be better standards that people can operate on. Although I will also just say, you know, we sort of make the standards by doing it, so they evolve over time, and it is important to start doing it. So that said, I just want to comment that I spoke with the system, a major health home system in the New York regional market, and about the possibility of exchanging care plans, and basically they said exchange credentials and log into the systems. So yeah. I think that organizations like Foothold and the Bronx RIO, among others, are going to kind of try to push this envelope for the next couple of years and get more people engaged in the idea that we have new ways to do these things, but it's going to take a little while.
Yeah, exactly. All right, terrific. I'm reading my message feed from Sarah, and I don't think we have any other questions. So that terrific presentation panel, I really appreciate your time on this topic. And to our audience, if questions occur to you after this event, please feel free to email us, and we will be sure to track down an answer for you. As always, we appreciate your time and attention on this webinar series, and we hope to see you again soon on another webinar of interest to you. And I wish everyone a great day. Thank you for your time, all.
Thank you.